So, the topic of today is going to be about infective endocarditis. And my message basically about infective endocarditis is to show how difficult the field of management of infective endocarditis is and the necessity for multidisciplinary team is always there. And before we start, is any one of you has any experience recently with a case of infective endocarditis?
Yes, yeah.
Uh-huh. Well, how was the final outcome?
Uh, the patient should be underwent surgery as soon as
Mm-hmm.
possible because it had complication. Okay, my case is
Oh,
21 years old, female, present with fever for about 2 months. She's diagnosed as malaria and pneumonia. When she represented, when we did an echo for her, it shows a tricuspid valve endocarditis.
okay.
She's a female with no history of anti-drug user and no devices.
Uh-huh.
After a course of 2 weeks of antibiotics, the culture was negative. We started empirical antibiotics. There is no improvement through an echo. The mass is showed it is elongated, and we thought about vegetation or fungal infection. So we consult our surgeons, and they decide to do an urgent surgery.
Okay. So the culture was positive,
No, it was negative.
was negative culture. Okay. So she underwent surgery, yeah?
On her way for surgery, يعني إن شاء الله
On
this
her
week.
way to surgery.
Yeah, yeah.
And she is an IV drug abuser.
No, she's not.
Uh-huh. She's not,
There's no,
but you said,
yeah.
uh-huh.
No, there's no
What?
history of IV drug user and no devices.
There was
That's
no
why we
history.
think it is weird to have a tricuspid valve endocarditis in this lady.
Mm-hmm. And she is not immunocompromised.
No, her virus screening was negative.
Good, good. Any other experience somebody want to share with us about infective endocarditis? Okay, so in this presentation of tonight, I wish we go together and cover the following points. The role of echo, transthoracic and TEE, the differential diagnosis of valve masses, complication of infective endocarditis, infective endocarditis team and center of excellence, indications for surgery and indication for prophylaxis. Okay, so if somebody sees this echo, it's supposed to be real time, but for a reason, it's not working now. If we see this echo, we see the mitral and tricuspid, which are pretty much normal. So, do you think such normal valve can still be a shelter of infective endocarditis?
Yes.
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 Okay. Yes. يعني infective endocarditis can arise on normal valve. That's right or wrong statement. According to you, it's a right or it's not wrong statement. يعني infective endocarditis can arise on normal valve.
Yes.
لكن how common is this? يعني the vast majority of infective endocarditis cases we see in clinical practice are arising from abnormal valve, rheumatic, degenerative, bicuspid, or arising from shunt or devices or prosthetic valve. Exactly. How common to see an infective endocarditis arising from normal valve? It is so rare. It is so rare. Actually, myself, I haven't seen any case in which there is infective endocarditis on normal valve. We were always able to elicit morphological abnormality in the valve to start with. But theoretically, yes, in cases of very virulent organism or immunocompromised patients or drug abusers, yes, normal valve might harbor vegetation. But the vast majority of infective endocarditis arise on top of a pre-existing valve disease. Okay. Now, this is the gross anatomy or the authentic anatomy of infective endocarditis in the mitral valve. And you could appreciate the devastating effect of vegetation. Because vegetation is basically and pathologically, it's an amalgamation of a thrombus and bacteria, right? A thrombus and bacteria. So the thrombus provides shelter for the bacteria, and the bacteria induces inflammatory reaction, and it might be virulent enough along with the inflammatory reaction to destroy the valve. So we might end up having dysfunctional valve either in terms of regurgitation or perforation or chordal rupture or aneurysmal formation or fistulation, different manifestation of devastation. Okay. Sometimes the vegetation might be big enough to cause an obstructive effect, but that's not as common as regurgitation effect. Okay. The regurgitation effect does not depend so much or firmly on the size of the vegetation as much as it depends on the virulence of the organism within the vegetation. But in case of obstructive effect of vegetation, it basically depends on the size of the thrombus. Okay. Now tell me what you see here. What is this? Any guess? So you can just guess. Try to guess.
The tri-leafed valve is vegetation.
I might make it easier for you.
Aortic root
abscess. Good. This one here, these are the cusps of the aortic valve, because here the aortic valve is stretched out. Okay, this is post-mortem, so it's stretched out. The aorta is opened up, so you see the three cusps in one line, and this is part of here, part of the mitral valve, and this part here is the intervalvular fibrosa, which is the place of abscess formation, right? The place of abscess formation. Good. Yani the abscess formation has a predilection to this area, the aortomitral keratin. Okay. So this is an abscess formation and probably fistula formation between the aorta and the left atrium. Okay. If you see this one here, that might give you an idea about how much the surgery is needed, but how much the surgery is gonna be difficult, because you are gonna operate on a very friable tissues and you need to do reconstruction, and so much difficulties are gonna face you. So we don't only need a surgeon, but we need surgeons of high expertise. Okay, That's the problem of infective endocarditis. You need probably surgery in a majority of patients, but the level of expertise the surgery are supposed to have must be high to deal with these tough cases. Okay. Now this is again vegetation of the mitral valve, and you could see that there are different shapes and morphologies of the vegetation itself. It could look like a piece of a meat, or it could be like, you know, a granulation tissue and purulent mass and stuff like that. That is basically depends on the microorganism, okay? The microorganism, because the bacterial repertoire of infective endocarditis is still wide, okay? We have classical organism, we have fastidious organism, we have virulent organism, less virulent organism, we have fungal infection, and all of that, okay? So depending on the microorganism, the morphology of the vegetation might change. Again, you see this is vegetation on the mitral valve, and it looks like a piece of blood clot. Now, the location of vegetation is on which side of the valve?
The mitral side.
Yes, when we are talking about the mitral valve, it will be on the mitral side.
On the atrial side.
On the atrial side,
Atrial
exactly.
side.
And very good, right. And in the aortic valve?
The LV side.
In the LVOT side. And in
In the
tricuspid
LVOT
valve? Exactly. And in the tricuspid?
Right atrium.
Right atrial side. And pulmonary valve?
RVOT.
RVOT.
RVOT. So that is called the upstreaming of the valve. So
Upstream is the
exactly, this is the upstreaming of the valve. So when the flow converges around the valve, that's where the vegetation forms. So imagine that the valve is on top, blood is coming towards it, and then departing away from it. When it's coming towards it, that is called upstreaming direction or upstreaming aspect of the valve. When it goes away from it, that is called downstreaming of the valve. So vegetation forms in the upstream of the valve, okay? Upstream of the valve. Now, what is this mass? What is this mass?
It's fibroelastoma.
Fibroelastoma. Okay, can you tell us more about it, Maria?
Yes.
So it is a mass
it's
attached
found
to
out when
the
you put
valve
it in the
side.
normal saline as is seen here.
Yeah.
Again, sorry, Maria, what did you say?
I said it is it will fan out when you
Yes,
put it in normal saline.
exactly.
And it is the most common tumor of the valves.
The most common tumor of the valve. So it's not the most common tumor of the heart.
Yes, of the valves. Yes.
The most common tumor in the heart, if we are talking about benign tumor, the most common primary benign tumor of the heart is myxoma. Yes. The second most common tumor, benign tumor of the heart is fibroelastoma. But the first most common valvular tumor is fibroelastoma. Okay?
Yes.
Fibroelastoma. So this is fibroelastoma. Can you describe it anatomically?
Myxoma.
We lost you. We lost you.
Stalk the
Stalk, yes. It has a stalk. What else?
shimmer like tumor.
Okay. Shimmery.
Mass, yes.
Exactly.
Um,
Exactly. So it is a piece of meat attached by stalk to the edge of the valve. Sorry, your sound is not so clear. Is my sound clear?
Yes. Yes,
Yeah.
clear.
Yeah,
Yes,
it's
It is
okay.
clear.
clear.
It's
Okay.
okay. It's on. شبكتنا
تمام.
تعبانة.
So yeah, we said that it's a piece of meat attached to the edge of the valve by a long stalk. Okay. And when you look at the piece of meat, you could appreciate the shimmer, like hairy ball. It's a hairy ball. Okay. And this could be appreciated even further when the tumor is impregnated in normal saline, it fans out, you know, like porcupine, you know. And they describe it like sea anemone, اللي هي شقائق النعمان, the one you see on the right bottom. Okay, that's how it looks like. And in echo, as we are always trying to look for the stalk and the shimmering feature of the head. If we see both, that is a high probability of fibroblastoma. But honestly speaking, it could be confused a lot with vegetation. مع إنه السايد بتاعها is not typical, right? لأنه السايد بتاعها is in the downstream of the valve, is on the aortic side, not LVOT side. Okay? طيب. Now what is this? Any guess? Any guess?
no.
Mitral valve.
Aortic. So this is called Lambert excretion. Have you
What?
ever heard about that? Lambert
No.
excretion. This is very important and you just have to know it so well because it is extremely common. We have seen it so commonly on the surface of the aortic valve. And sometimes it can be big enough to be confused or perceived as vegetation. So as you see here in the gross anatomy, they are thread-like, you know, arising from the edges of the valve. And they thought of it as part of the degenerative process of the aortic valve. So expectedly to be seen in elderly with degenerative aortic valve. So it's fibrous, you know, linear threads arising from the edge of the valve. And when the valve closes, they prolapse into the LVOT. So making it even difficult for us because it is typical location for vegetation in the LVOT site. Okay, good. So there are so many cases actually labeled as vegetation in the aortic valve, but it was just Lambert excretion. So Lambert excretions can masquerade so well as vegetation. And Lambert excretions are common. To me, actually, it is very common. very common. It's much more common than fibrillostoma and all of that. Okay, these are the Lambill excreta. So you have to remember that Lambill excreta. Okay. And now,
Okay.
what is this? This is the mitral valve. Again, it's opened up, it's stretched out in autopsy sample. And you could appreciate something abnormal in this valve, which is any guess? You see these nodules,
Yes, sir.
erythematous nodules.
Yes, looks bad.
Yes, exactly. So this is again an abnormal valve due to this erythematous nodule, and this is a case of Liebman-Sack endocarditis. This is Liebman-Sack endocarditis, and as you could appreciate in echo, in Liebman-Sack endocarditis, you will have kind of symmetrical lesions. So when they contact symmetrically. That's why some people love to call them kissing lesions, because they are symmetrical on the anterior leaflet and on the posterior leaflet. So when the valve closes, they are like kissing. So this is one thing. The other feature of Liebman-Sack endocarditis is not, the vegetation are not that big, They are more or less nodular thickening, and they hardly arise away from the boundaries of the valve, so much like conventional vegetation. Okay, but this will bring us to talk about the non-bacterial infective endocarditis. You know this terminology?
Yeah,
What is it?
it is endocarditis caused by other other causes rather than bacterial, like malignancy, also like SLE, or caused by fungal infection.
I agree with you, but let's just cancel the
Is
last
it
part.
marantic, Dr. Hatim?
Not
Marantic?
fungal. Yes, not fungal infection. You are right in all. It is, yeah, it is called non-bacterial infective endocarditis. It's called marantic endocarditis. It's called verrucous endocarditis. These are all the same terminology. Okay. Basically, it's a thrombus without bacteria. A thrombus without bacteria. The vegetation has three components. The vegetation of the conventional infective endocarditis has three components: bacteria, thrombus, inflammatory cells. Now, in this case, it's just a thrombus, so it's just platelet and fibrin. No bacteria, no inflammatory cells. Okay. Well, like you have listed, the causes are like autoimmune connective tissue diseases, hypercoagulable states, malignancies, debilitating diseases, and stuff like that. And that's why, because they are basically a thrombus, mostly are clinically silent and mostly are undiagnosed. وغالب الdiagnosis of marantic endocarditis is established at postmortem. Okay, postmortem. So the clinical expressibility of sterile vegetation is not like an infected vegetation. يعني الclinical course of the conventional infective endocarditis is so, pronounced. لكن sterile vegetation being on the valve might just go silent and the patient might die with it. Okay. فلذلك الdiagnosis is basically established at postmortem. Okay. لكن برضو عندها مشكلة أساسية this sterile vegetation أو thrombi. And chances of embolization is high, right? The chances of inflammation is high. Okay. So basically, Merantic endocarditis is unlikely to destroy the valve like conventional endocarditis, but it's probably more likely to embolize distally. So the thromboembolic phenomena is appreciable in this patient. Okay. Again, this is what is this? What is this? Again, this is an aortic valve opened up, and you could also appreciate vegetation on the LVOT side. But these are smaller than the vegetation we have seen in the first case and is not destroying the valve like the first case we have shown. Okay. Now, what is this? What is this? Any guess? Is it normal or abnormal valve? This is mitral valve, right? Is it normal or abnormal?
Looks like this is calcification, heavily calcified valve.
It looks like calcification in a way, but this is not calcification. This is myxomatous valve, exactly. And in fact, this is the Barlow's type of myxomatous valve. So there is, yes, there is excessive tissue and redundancy forming lumps on the leaflet, and there is redundancy of the chordal system as well. Why have I brought this slide here? Because there are so many times, by the way, we have misdiagnosed infective endocarditis in a patient with myxomatous valve, because in echo, we see that the valve is lumpy, you know, and excessive tissues, and we feel there is vegetation there. So this is again one of the things that you should be aware of. The myxomatous valve might sometimes be perceived as harboring vegetation, while that is nothing but the redundancy of the leaflets and the prolapse of the scallops, and no more than that. Okay, but the thickness of the valve, the redundancy of the valve, the excessive tissue in the valve might give the impression of vegetation. Okay. Now, what are the complications of infective endocarditis you know about?
Either destruction.
Sorry, again?
Embolism. Destruction of valve by either apis or fistula.
Yes.
Complication, conduction abnormalities, embolic septic embolism or embolism.
Yes.
Heart failure can be one complications. Mechanical mitral valve rupture, severe MR, acute severe MR.
Very good.
Some sort of vegetation, CNS.
Let's take it one by one, and you just stay with me. You said regurgitation. Can you tell me about the mechanism of regurgitation in infective endocarditis?
Sorry?
How the mechanism? Yes, destruction of the leaflet. Good.
Perforation of the leaflet.
Perforation of the leaflet, yes.
Rupture of the chordae.
Rupture of the chordae, exactly. And if you have prosthetic valve, the infection might extend periannulary and lead to dehiscence, and this will lead to proverbial leak. Okay, so these are all mechanisms. So perforation of cord, perforation of the leaflet, destruction of the leaflet, aneurysmal formation of the leaflet, and in prosthetic valve, dehiscence of the ring. These are the mechanism of regurgitation. Okay. So regurgitation is one of the complications of infective endocarditis. We said that stenosis relating to the bulkiness and the size of the vegetation is another complication. Dictora Bardo mentioned about embolization. Okay, what else?
Heart failure.
Heart failure. And this heart failure is usually through
Acute rupture of the chordae.
exactly. It's either through these mechanical complications, right? It's through fistulation or through acute regurgitation or stuff like that. Exactly.
Yes.
Okay. What other
Abscess formation?
Abscess formation, exactly.
Abscess formation.
Yes.
Bacterial infective.
Sorry. Abscess formation. What else?
Bacteremia and septicemia.
Okay, bacteremia, septicemia. Yes, exactly. And I think somebody also mentioned the mycotic aneurysm. Mycotic aneurysm. You know mycotic aneurysm?
Yes, it
Do you know?
infected
Yeah.
embolization to the brain.
Mycotic, yes, embolization. But do you know about mycotic aneurysm? Is one of the complications, and in which the infection feeds in the vessel wall and leads to saccular dilatation, aneurysmal formation, and it might rupture, leading to bleeding and stuff like that. I actually have seen 3 cases of mycotic aneurysm with infective endocarditis. One was affecting the mesenteric artery, one of the cerebral artery, and one of the coronary artery. Okay. So mycotic aneurysm leading to this saccular dilatation and possibly rupture. So it is a very essential complication, and it portends very poor prognosis. Okay. Now fistula formation.
Regarding the right side.
Yes. The right side.
Can lead to multiple lung abscess.
Exactly. Yes. Embolization to the lung leading to multiple lung abscesses. Exactly. You're right. Good. Now look at this slide. Actually, this is a real patient. The one down is my patient, actually. But if you see, this is called aortocameral fistula. So there is fistula formation between the aorta and a chamber. This chamber could be the right atrium, as you see on the slide on top left, or the RVOT, or the left atrium. So it could be aorto right atrial fistula, aorto RVOT fistula, or aorto atrial left atrial fistula. Okay. So whenever you have vegetation of the aortic valve, usually associated with abscess, that abscess might burst. Okay, and it bursts in one of these 3 chambers. Okay, so it might burst exteriorly and lead to devastating tamponade. Like it might be contained within one of these 3 chambers. That is called aortocameral fistula. Okay, and believe it or not, the patient here on the lower side was a patient of mine and was recently came out of bioprosthetic aortic valve surgery, and he was doing fine. I think the 4th day post-op, he started to develop shortness of breath and found to have pulmonary edema. So we have done transthoracic echo and we found that his ejection fraction has dropped from baseline of 50% to 20%. So we thought this is probably something relating to the ischemia bypass time and stuff like that. But finally, we settled on doing TEE. And when we have done the TEE, we found this fistula between the aorta and the left atrium. So the fistula has actually led to this LV dysfunction. And the patient went in heart failure due to this fistula. Okay. Yes. And unfortunately, it's not working. But this is the same patient I'm talking about. And you see here, I want to just alert you to this. Look at this part here. You see, it is kind of thick, right? You agree?
Yes.
Yeah.
Yes.
Just let me mute. Okay. So this thickening, and here also, you see this one, this part here is thick. This part is thick. So the aorta is here. That's the aortic valve. The mitral valve is here. This part is thick. The thickening of the aorto-mitral junction or intervalvular fibrosa is so important. If you appreciate thickening, take it seriously, because that might be the forerunner of abscess. When it is thickening, yes, only, they call it phlegmon. Phlegmon. Phlegmon is the precursor of abscess formation. So after some time, it will be an abscess. This is the initial stage of abscess formation. It's induration and thickening of this area. Then after some time, you will appreciate the necrosis and the fistulation, which is late stage. But the early stage, you won't appreciate necrosis and fistulation. You just appreciate thickening and induration. It's called phlegmon. Okay. So thickening of this area should always be taken seriously, and you have to take it all the way back into the clinical scenario of the patient. So if the scenario is suggestive of infective endocarditis, I think you should start management. I have encountered two cases. In these two cases, the first manifestation of infective endocarditis was this phlegmon formation. Okay. The first case was the patient post-TAVI, and I think few months after TAVI came with fever and vague symptoms of ill health and stuff like that. And his ECG was showing extreme first degree heart block. We have done transthoracic echo and it was unrevealing. They have done TEE, and I thought, and I was actually opposed by my colleagues in the department that this is nothing, but I was seeing it as phlegmon. Okay. And because I was the youngest in the department, I have to shy away and say, okay, whatever you think. But after a week, the patient went worse, and they have done TE again. And this time we have seen the valve has already embolized, and there is a clear abscess formation. When the patient went for surgery, the abscess was already in the aorta. Yeah, so it migrated into the aorta. Okay, so what is the most important tip-off to abscess formation in this patient from this scenario? And I wish you answered this question right.
looking for the ECG for DR interval.
Thank you so much.
Yeah.
Thank you so
Prolongation.
much. Exactly. So whenever you are suspecting or a patient is having an aortic valve vegetation and he develops any type of conduction defects, think of an abscess formation. Okay. Sometimes the abscess, the conduction defect precedes the vegetation itself, and the full-blown abscess we see in echo. You know, sometimes it precedes it. Okay. So ECG is important in these patients, by the way. Okay, you have to study it so well. So this is a patient of aortic valve infective endocarditis, abscess formation, and fistula between the aorta and the left atrium. Unfortunately, it's not working, but the blood is flowing in this direction. I can show it to you here. You know, this is the fistula. This is the aorta here. This is the left atrium, so the flow is going in this direction. Okay, you see it here. That's the direction of the blood flow. Okay. Now, what is this? Anybody? Don't ask me to freeze. It's designed to work this way. So just grasp the diagnosis or guess it anyway. You can describe it, Yani, to get some.
Mainly in the aortic side.
Yes.
So unlikely to be a vegetation.
Sinus of valve rupture.
It is very hard to say rupture. I know what you are seeing is probably a slit in the one of the coronaries, but it's difficult to tell from here. It might just be an echo dropout for some reasons, but unless you demonstrate a flow through that hole, you won't say rupture of sinus of valve. But the most important finding here is this mass. So let's
It's
carry on
attached to the
describing
right
yes.
coronary cusp.
Okay.
Like fibroblastoma.
Why did you say fibroblastoma?
It is on the aortic side, not the LVOT side.
Good. And
Attached with
it
the
has a stalk.
Attached to the valve.
It has a stalk.
Yes, it has a stalk.
Yes. And if you
Yeah.
have the chance to stop freeze and go frame by frame, you could even demonstrate the shimmering edges of the head of the mass. Okay.
Okay.
This is fibroblastoma. Good.
Okay.
And is it large enough to qualify this patient for surgery? Yes. Yes. I think if it's more than 1 centimeter, patient should go for surgery because it's associated with embolization, right? Yes. Good.
Yes.
Now, describe this echo here.
Like a fistula.
Preston along with view showing
There is
looks like a
nothing on the right
vegetation
side,
in
by the way. Yeah. Again, go ahead. It looks like vegetation on
With mitral valve rupture.
and
Prolapse.
This is the rupture. The anterior leaflet is prolapsed to the LA.
yes,
Seems
exactly.
like
Yes.
it
Caudal
seems
rupture.
like caudal rupture. Yes.
Caudal rupture, exactly. But there is another finding, and I think that some of you have stated that right. There is a, I think, don't look at the right side because you know the image is not so well oriented. He's going from the parasternal long axis into the RV inflow in one image. That's why the tricuspid valve is open. But let's focus on the mitral. We have a rupture
vegetation.
cord. and flail anterior leaflet. Yes, there is what? Probable vegetation on the posterior leaflet, right?
Yes.
يعني the posterior leaflet, there is a
Yes.
mass. There is a mass on the posterior leaflet as well. If this is also rupture cord or whatever, we can't tell. But if this is a vegetation, it is kind of calcified vegetation, right? You know, calcified vegetation. This is a
Yes.
patient who had renal failure, and they have requested this echo just routinely. He is end-stage renal disease on hemodialysis. They have done echo, and that's what we have seen. So, will you diagnose infective endocarditis based on that?
Most likely Dr. Hand degeneration.
I think the mitral valve from the start is rheumatic types. It's elbowing. There is elbowing of the anterior leaflet.
So you think it's rheumatic? Okay.
Because end-stage renal disease is associated with the degenerative of the valve. That
So
seems
you
like
think this
one
is
of the
all
disease
degenerative
process.
changes? So you think what
And
we
the
all see
anterior
here,
and the anterior leaflet is more flail
yes,
because
it's
the
flat.
tip
Yeah,
is more than prolapsing because
yes,
the tip
it's
is
flat. Yeah, I agree with you. The patient has severe mitral regurgitation due to prolapse anterior leaflet due to rupture cord. Yeah, but are we dealing with infective endocarditis in this patient? Infective endocarditis is never about what you see in echo. It's about clinical constellation and the criteria, modified Duke criteria. You have to bring it all together on table and discuss the case. But you cannot tell that this patient is infective endocarditis just based on echo findings. Okay, this might be chordal rupture. It might be calcified degenerative masses. It might be old healed vegetation. It might be subacute chronic endocarditis. It might be so many things. Okay, so infective endocarditis, if you stumble upon, like in this case, you stumble on a mass on the mitral valve, you cannot tell this is infective endocarditis based on echo. يعني حتى لو افترضنا انه مع انه الفيتشرز بتاعتها is not so typical of infective endocarditis. لكن if we go by the typical description of infective endocarditis to qualify the mass to vegetation as per the guidelines and as by the Duke criteria, that will be one major criteria. So to diagnose infective endocarditis, you need two major, or one major and three minor, or five minor, right?
5 minors.
Exactly. يبقى بالتالي ما في don't commit yourself to the diagnosis of infective endocarditis based on echo alone. Okay. الغريبة يا اخوانا البيشنت بتاعين ال end stage renal disease, I have seen so many patients with masses like this. And when we go into their clinical history and we even dig deeper by inflammatory markers and cultures, nothing is positive. So it's probably all healed vegetation of subacute chronic endocarditis, or it could be degenerative changes, you know, because these patients are having enhanced degenerative process of the valve, and the valve might form this nodular calcification, which looks like masses. Okay. It's hard to diagnose infective endocarditis based on imaging. Type, what is this? It is mitral valve endocarditis. Can you describe this mass? How can you describe the mass?
This is oscillating, really mobile.
Exactly. Is it large or small or intermediate?
Large.
Large based on, yani how do you define large vegetation? When it measures
More than
1 centimeter.
more than 1 centimeter, exactly. So if I have vegetation like this, if I have vegetation like, how can I measure it? And what does it mean more than 1 centimeter? Does it mean on this axis or on this axis?
The maximum diameter.
Exactly, the max. Yani if a mass is just like thin like a thread, but it measures more than 1 centimeter, is considered large. So large in the longest axis. Okay? Like in
Yes.
this patient might be large in both axes. Okay?
Yes.
Good. So it's oscillating, mobile, and large. So how many predictors of embolization we have in this patient?
It's high possible to,
The size
High,
of the
high
diameter of the
possibility.
mass,
because it
Yes.
is mobile
Now,
and
Anna,
at
I
the
want
tip
you
of
to
the
tell me
valve.
about five.
hypermobility.
Exactly. Mobility and size. I need more 3.
Mobility and the size of
The shape of the mass.
The shape of the mass.
And if it is pedunculated or
The site also, the site of the mass.
The site of the mass. What do you mean by that?
If it is in the mitral, it is most likely to embolize in the
Then?
mitral valve
Then
than the aortic valve. Than the aortic valve.
exactly. Mitral more than aortic. وطبعا دي counter intuitive. يعني الناس بتتخيل انه الاورطه is closer للبلود stream, systemic blood stream, so it's more likely to embolize. لكن no, mitral masses are more likely to embolize than aortic masses. And what else? Being on which leaflet of the mitral valve? On the anterior leaflet. So the size of the mass, the mobility of the mass, being on the mitral valve, being on the anterior leaflet. Okay? Good. Okay. Now, again, this is a different mass. Can you describe it? Is it mobile?
Yes.
Yes.
No.
Is it here you might say
attached?
no as attached, yes, but look at something that comes at the peak of the mass. The mass is composite of 2 masses, fused together. The one broad based on the leaflet, and there is one that comes on top of that. You see that one? Did you see it?
Yeah.
Yes. So that one is mobile. So if there is mobility in any fragment of it, we consider it mobile. Yes. So we have mobile. And the other thing is that it's kind of heterogeneous. There are echo densities are different. There is probably calcification on the mass. You see the echo density inside the mass. Okay. Heterogeneity of the mass. وهم حتى بيقولوا الهيتروجينيتي might be associated with embolization برضه when it is heterogeneous. Being heterogeneous, being irregular in contour. لكن the two most important characterization of the vegetation as to embolization is the size and mobility. Okay, the size and mobility. لكن we also have to remember the other factors. Now, what is this? What is this?
This is Mugdamitous mitral valve.
Okay.
It is fixed, distorted.
لكن الميكسوميتس mitral valve, yes, because you see a linear mass arising from, I think you could appreciate that, right? And this one here.
Yeah. Exactly.
Mhm.
Yeah.
You could see it, huh? This one that comes here. You see that
Yeah.
one? Yeah. So I'm sorry because it's not clear here, but this is bioprosthetic mitral valve. These are the struts here. You see the struts here and here. So it's supposed to be looking like two struts like that, and the leaflets are in the middle. But both leaflets are so fleshy and thick because of adherent vegetation, and one of which is having an elongation into
Perforation.
a larger mass. Okay, so this is vegetation of bioprosthetic mitral valve. And do you think there is mitral regurgitation here?
شنو أبغى question؟ قصده
Most
حمام؟
probably.
Do you think there is
Yeah.
mitral regurgitation?
Yes.
Why
Dehiscent
did
of
you
the
think so?
There is
Malco up.
Yes, exactly. So they are kind of torn leaflets. The leaflets are torn. They are now, are not fixed to the struts as they are supposed to be. So they are so flexible now or torn, and they are prolapsing so much into the atrial side. So this patient is having severe mitral regurgitation along with these vegetation due to these vegetation. Okay. What else do you see in the left atrium?
there is perforation of the
Contrast, echo-spontaneous contrast.
Exactly. Thank you so much. Thank you so much. There is echo-dense contrast. Now, echo-dense contrast, a patient with mitral regurgitation, you expect dense echo contrast.
so there is some sort of stagnation.
Why this stagnation? Usually we see it more with
So
The
there
valve
is
stenosis, right?
mitral stenosis
More with
and
stenosis. Okay.
mixed mitral
You-
valve.
or mixed, yeah. Do you think that this mitral prosthesis is stenotic?
due to obstruction of the valve by the mass.
Exactly. This is one contribution, and the valve itself is probably degenerated to start with, and on top of that, infective endocarditis came. So this is severely stenotic valve. So the valve was stenotic and regurgitant. Is there any other finding?
There is
It means
perforation of the leaflet.
where? Perforation of the leaflet is very difficult to tell here. Lakin, are you alluding to this hole? I'm gonna point to it and tell me. Do you think about this part here?
Yes.
Yeah. So this is not the leaflet. This is the struts. There is paravalvular leak through this hole. So this is dehiscent ring. The ring or the sewing ring is dehiscent as well. So this patient is having probably three complications. One is dehiscence of the sewing ring leading to paravalvular leak, destruction of the leaflet of the bioprosthetic valve leading to regurgitation, and severe stenosis of the prosthetic valve. Okay, good. Okay. So far we are fine.
Yes.
Yeah.
Now,
Yes.
I am gonna ask you a very simple question. A patient is sent to you from internal medicine department as suspected case of infective endocarditis. You have done transthoracic echo. It is positive. You have seen vegetation on the mitral valve. The patient, according to the Duke modified criteria, along with the vegetation you have found color, that is infective endocarditis. Are you going to stop here or you're going to proceed to any other workup?
Do theory.
So you are going to go for transesophageal echo, huh?
transesophageal echo and blood culture.
TOE.
And yeah, هم طبعا they have done the blood culture and the clinical evaluation, and they have put the patient as probable infective endocarditis, and you have found the vegetation. So they already have two major criteria and whatever minor criteria. So they established the diagnosis of infective endocarditis. Now, are we going to go for transesophageal echo despite establishing the diagnosis of infective endocarditis?
Yes,
Yes.
According,
Why?
if there is indication.
no
If there
indication.
is
All the patient with infective endocarditis.
all the patients.
No
Okay.
indication unless there is deterioration of the management or there is no response.
No,
أيوة.
any patient with definite or positive or rejected should have transesophageal echo.
Okay, so we have a dispute here.
Yeah.
Yeah, good. هي حقيقة القضية شوية حامية الوقت أنا I know. ولكن الجايد لاينز كالآتي. Transesophageal echo provide two opportunities: diagnostication and prognostication. Transthoracic echo usually provides diagnostication tool. So if you have diagnosed vegetation based on transthoracic echo, you still need transesophageal echo for prognostication. And by prognostication means better sizing up of the vegetation and to see if there is any valve destruction and to see if there is any periannular extension of infection. So all patients with positive transthoracic echo, they have to go for transesophageal echo. حتى بعد الدايجنوستيك على الترانسوفاجيال ايكو. هنا بيكون الغرض بتاع الترانسوفاجيال ايكو is not diagnostication لكنه prognostication, which is again important. Okay. طيب إذا لقيت الترانسثوراسيك echo is negative, what am I gonna do?
I will do TOE also. TOE also.
We did TOE for diagnostication and prognostication in this type of
Please,
patient.
thank you so much. يبقى if I have a positive transthoracic echo, I have to go for T for prognostication. If I have negative transthoracic echo, I have to go for transesophageal echo for diagnostication and prognostication.
Diagnostic.
Right?
Yes.
طبعا الامر ده doing transthoracic echo followed by TEE ولا stopping at the level of transthoracic echo برضه it depends sometime on clinical evaluation. يعني إذا جاك patient very low probability of infective endocarditis based on the criteria. عملت transthoracic echo, it was so great image quality, the valve are morphologically normal and no vegetation. You might stop here. Okay? لكن إذا البيشنت عنده prosthetic material or prosthetic valve, I cannot stop in transthoracic echo لأنه sensitivity of transthoracic echo for infective endocarditis is in the range of 40-60 while TE is in the range of 90-100. Okay? لما يكون كمان عندك prosthetic valve, a sensitivity of transthoracic echo even drops further. It drops further. Why it drops further? لأنه prosthetic valve is contaminated with acoustic shadowing and reverberation artifacts that might conceal your visibility of the valve. بالذات للmitral valve. يعني let's see this one here. This is transthoracic echo on the left side. What we are seeing, parasternal and apical four-chamber, right? Parasternal and apical four-chamber. Now the valve is here. That's the metallic valve. This is metallic mitral valve. We are seeing acoustic shadows here, probably coming from the aortic valve. And I'm seeing here, what am I seeing here? I'm seeing two artifacts. The reverberation artifact, this one, and the shadow, acoustic shadow artifact on the other side, on these two sides. So the left atrial side of the valve is completely concealed by two artifacts. Reverberation artifact in the middle and two acoustic shadows on both sides of the valve. So you are bound to miss vegetation if it exists. Okay? Why do I have this? لأنه ultrasound beam is going this way. Your beam is here. So it's hitting the valve this way and it forms the reverberation and the acoustic shadows on the atrial side. Compare this to the transesophageal echo. In transesophageal echo, you still see the two artifacts, but in this time you are seeing it on the LV side. These are the reverberation artifacts is here and the acoustic shadow artifacts are here. But the left atrial side of the valve is now clean. Why is that? Because the ultrasound beam is coming from above and the shadows are formed below, away from the mitral valve. So this is so important that TEE, transesophageal echo, is going to clear the mitral valve from reverberation and acoustic shadow artifacts. That's because of the direction of the ultrasound. Yes. يبقى في وضع كبير جدا هنا الآن. انت you can see vegetation here, you can see paravalvular leak in transesophageal echo, but you are so likely to miss vegetation and paravalvular leak in transthoracic echo, prosthetic valve, metallic valve, and stuff like that. Okay?
Yes, very interesting.
Did you get this point?
Yes.
Yeah.
No.
Good. No?
Yes.
No. Okay.
We got it.
You get it?
Yeah.
Right.
It is clear.
No, not clear.
Who is saying not clear?
Not clear.
طيب يا سهير. طيب. هي الفكرة الأساسية is the direction of ultrasound. Okay. طبعا احنا we are talking about metallic ولا حتى bioprosthetic mitral valve. بيعملوا the same problem. When we are scanning the patient by transthoracic echo, هيكون عندنا artifacts مع prosthetic mitral valve. These artifacts are generated because of the direction of the ultrasound. يعني مثلا الآن if you have this, let's see this one. Sorry. Okay. If we have, let's say, we have this structure, dense structure, and we have an ultrasound beam coming this way. The ultrasound beam is gonna form two artifacts on this side. One is reverberation artifact along the back of the mass and acoustic shadows on this side. So all this side will be concealed by two types of artifacts, reverberation artifact and acoustic shadow artifact. So if I come here to the transthoracic echo, look here, the ultrasound is coming in this direction. It's coming from up, down, from the apex to the, from the apex to the valve this way. And that's why you see this comet tail artifact. The valve is kind of magnified so many times, and this the left atrium is all filled with the valve. That is reverberation artifact. And also we are seeing on both sides a shadow artifact, something shadow, acoustic shadow artifact. So the entire left atrium is hidden away. So I cannot see paravalvulally, I cannot see vegetation on the atrial side of the mitral valve. But if I do TEE, that's TEE on this side. The ultrasound is coming from up, down. reverberation artifact is gonna form, but this time is gonna form on the ventricular side. The acoustic shadows are also forming here, but all on the ventricular side, which is not area of my interest. The area of my interest is the atrial side of the mitral valve, which is now clean of any artifacts, and I can see if there is vegetation, I can see if there is paravalvular leak.
Yes.
So whenever you have a case, whenever you have a case of prosthetic mitral and you are suspecting or you are dealing with infective endocarditis or paravalvular leak, don't hesitate to go for TE. Don't hesitate على الإطلاق. Okay?
Yes.
Good.
يعني regarding the prosthetic valve, it is better to do TOE for the diagnosis and prognosis.
Exactly. Exactly. Okay. Now,
Thank you.
so we have spoken about the embolization and the determining factors of embolization. We have talked about mycotic aneurysm and what does they know or they do, and fistulation, abscess, heart failure, and we talked about conduction defects. And we said that the conduction defects underscore the importance of ECG. And in fact, ECG should be part and parcel of the management of patient with aortic valve endocarditis. And I think it should be done daily to follow up these patients. If they develop any conduction defects, that might indicate abscess formation. Okay. So ECG is important in the management of patients with aortic valve endocarditis. We have talked about the valvular destruction in terms of abscess formation, fistulation, aneurysm formation, and dehiscence and perforation. Okay. Now, there is a patient. There are patients. You do TE, you do transthoracic echo followed by TE, and negative is still. But the clinical suspicion of infective endocarditis is still high. Culture is positive. So in these patients, are you gonna close the case based on no evidence of infective endocarditis, or you are gonna proceed further?
No.
You
We can do another imaging modalities to
which is
we can do an CT, cardiac CT.
Okay.
AMR.
We can do a PET scan or respective scan.
Okay.
We can repeat the echo.
Oh, thank you so much. You have mentioned them all. So one of the things that if we have high clinical suspicion and we have negative transthoracic and TEE, don't give up. Okay. We can repeat TEE after a week and we might see something evolving. Or you can go for advanced cardiac imaging like CT, CT SPECT, and CT PET. And these imaging technologies are now in the guidelines are class 2. وده طبعا بيأكد على أهمية المالتي ديسيبلينري تيم ابروتش لأنه الانفكتيف اندوكاردايتس الآن so far we said that it needs transesophageal echo, it needs transthoracic echo, it needs an expert cardiac surgeon, it needs multi-imaging modalities sometimes, it needs a tough and complex antibiotic regimens which necessitate infective endocarditis consultants. So there, the approach should be multidisciplinary. You know, it's very difficult for a single physician to deal with it. And كده guidelines are now calling for establishment of referential hospitals or centers for infective endocarditis and infective endocarditis teams. طبعا you know heart team صح؟ heart team, الهارت team. You know the heart team صح؟ الهارت team لاحظوا أنا ما بتكلم عن الانفكتيف endocarditis team. I'm talking about the heart team. Heart team is class what in guidelines? الهارت team.
في الانفكتيف endocarditis ولا in general؟
لا in general heart team.
Class 1. Endocarditis is
Yes,
class 1.
it is class 1. Class 1 means what? We should have it and we should do it. Heart team is class 1 indication in the guidelines, meaning يعني we have to have a heart team approach to complex cardiac diseases, valvular diseases, and revascularization, complex cases. We have to discuss it broadly among a specialized heart team to decide on the case based on individual scenarios and analysis. Okay, that is heart team. Now it's class 2. Infective endocarditis team is class 2. Class 2. Okay, يعني it's reasonable to have it and it's beneficial to have it given the complexity of the cases of infective endocarditis and the necessity for a specialized center, a specialized imaging, advanced imaging, a high surgical expertise, and so on and so forth. الآن مثلا, this is a patient who was negative based on TEE and they have done CT. The one on the left is non-contrast CT and the one on the right is CT PET, using the 5-fluorodeoxyglucose. Okay, what do we see here? عشان كده أنا عايزكم تتخصصوا في الكاردياك CT. يعني الناس اللي بيتخرجوا منكم ما كلهم يمشوا على الإيكو. We need some of you in advanced cardiac imaging. We need some of you in spectrum, PET and CT, okay? Good. Yeah. Exactly. Okay, great. You are talking about this part, huh? This one here.
Yes.
Okay. But before you look in here, this is a metallic or prosthetic mitral aortic valve, right? And there is filling, soft tissue filling around it here by the non-contrast or contrast CT. Now, if you look at the fluorodeoxyglucose, there is increased uptake around the valve, and this indicates a periannular extension of infection. So abscess formation. Now, this patient has negative TEE because no vegetation, and we know that TEE can miss early stages of abscess formation. Lakin, the metabolic scan is unlikely to miss it. Okay, so this is a case of infective endocarditis in which the diagnosis is established based on advanced cardiac imaging. T was negative. Okay, so you cannot
excuse me,
close the case.
Saya,
Yes.
but even in the prosthetic valve, even without infective endocarditis, the uptake is increasing.
في حالة واحدة,
like
I agree with
normal.
you. No, this is good point actually, and I wanted to mention it. When we give 5-fluorodeoxyglucose, this is a metabolic scan. So it goes where there is an increased metabolic activity. Now, الدكتورة قالت إنه البروstatic valve is inherently hypermetabolic. So whenever you do a metabolic scan, there will be increased uptake around the valve. Do you agree or disagree?
يا جماعة معايا ولا ما معايا؟
لا معاك agree.
Yes, we agree.
يبقى معناته إذا ما في فايدة من الميتابوليك سكان للبروستاتيك فالف. So why are
ما
we
نحن دايرين
diagnosing?
نعرف what is the difference? What is the
أيوة
difference between the uptake, normal uptaking of the prosthetic valve and the when there is infective endocarditis?
Good. طيب, the only thing that the valve, the prosthetic valve, will be metabolically active without infective endocarditis or abscess is the first 3 months after implantation, after which it should be metabolically inert. ليه بيكون initially؟ لأنه initially بيكون في granulation tissue and healing process going on, so it will be hypermetabolic. These are only 3 months after surgery or after implantation. بعد كده خلاص. ولذلك بيقول لك الميتابوليك scan for infective endocarditis is not good for patient recently coming out of surgery within 3 months. لكن after that, if you demonstrate a hypermetabolism around the valve, this is something worrisome. Okay? You get the point?
Yeah, thank you so much.
Oh, good, good. And here again, the aortic valve with hypermetabolism around the valve, indicating a periannular extension of infection. And this is actually, again, a PET scan, CT PET, and it is lighting up in certain points, indicating a widespread infection. You see here, this is an ICD, an ICD lead. This one is the generator. Sorry. You see this one here? This is the generator on the chest. And you see it's infected because it's hypermetabolic, and the lead and around the tissues of the heart. So the infection, and here also in the veins, and the infection is wide. Okay. This is a device-related infective endocarditis. Okay. Good. Are you following?
Yes.
Yeah, with you.
Yes.
Okay. Okay. So now the last thing, I'm not gonna walk you through the guidelines or anything like that, but let's just talk about the indications for surgery. When are you gonna take patient for surgery?
Okay.
There is no response in a fight.
Patient with heart failure, refractory pulmonary edema.
Sorry?
In patient with refractory pulmonary edema or heart failure, should go for surgery. Also, the patient
Okay.
with resistant or untreated infection, uncontrolled infection,
Okay.
or recurrent embolization.
Okay.
Prosthetic valve endocarditis.
Prosthetic valve endocarditis. Prosthetic valve endocarditis, I will take it with a pinch of salt, because per se is not an indication for infective endocarditis unless it's damaged. There should be a damage. So there are some indication relating to heart failure. And if there is heart failure, especially with hemodynamic compromise, patient should go for surgery as emergency, meaning as few hours as possible. Now, the rest of the indication are either urgent, meaning within 48 hours, or elective, within few weeks. Lakin, believe it or not, probably the vast majority of patients will need surgery. Okay? اللي بيحتاجوا emergency حقيقة ما كثيرين. لكن elective and urgent are a lot. Okay? Now, heart failure due to the complication of infective endocarditis mandates surgery as emergency. Now, if I have uncontrolled infection after antibiotic, or if I have large vegetation with or without embolization, or if I have damaged valve with paravalvular leak and with regurgitation and all of that, these are all indication for surgery, urgent and elective. So the only indication for emergency surgery is heart failure, especially with hemodynamic compromise. Lakin the other indications are resistant bacteremia, mechanical complication like dehiscence and regurgitation and paravalvular leak and perforation and aneurysm formation and fistula formation, large vegetation with or without embolization. Okay, يعني the indications are there. Okay. Okay. The last thing, and before I open it up here, do you give prophylaxis for special patients against infective endocarditis? and which type
Yes.
of patients you are going to give prophylaxis for.
Okay. Patient with previous infective endocarditis.
Exactly.
And the patient with congenital heart disease, if it is cyanotic, or have a surgery but with residual shunt or regurgitation.
Very good.
And in patient في واحدة ثالثة نسيتها.
Prosthetic valve.
Prosthetic
Prosthetic
valve, yes.
valve. Exactly.
Heart transplant with vascular.
Very good. Very, very good. Exactly. So it is prosthetic cardiac valve, previous infective endocarditis, congenital heart disease, cyanotic and repair, or completely repaired with prosthetic material or device during the first 6 months after procedure, or if they have residual defects at the site of prosthetic patch or device and cardiac transplantation recipient. So we have 4 indications for prophylaxis. Now, the level of evidence here is what? What is the level of evidence?
Class 2A.
Class 2.
Why?
2A, I
Why is
think.
class 2? Why is not class 1?
ما عملت randomized control trials عليها.
Never. You know, when we have been doing prophylaxis wider, and now when we have shifted since 2007 to only these 4 groups, there was no evidence. It was just consensus, and that's it. And some observational studies, but nothing like randomized control trial. And I don't think it's going to be done. So that's why the level is not strong. The level is not strong. Okay? And I think by this, we come to the end of the presentation today or tonight. إذا عندكم أي أسئلة, you are most welcome. Good. So that is fine. Now that conclude the infective endocarditis, and I'm so hopeful that I have given you an idea about the masses that might masquerade as vegetation and the role of advanced cardiac imaging, and how complex is infective endocarditis, how complex infective endocarditis is, and the necessity for multidisciplinary team approach. Next week, inshallah, I'm gonna announce the next session. وأتمنى إنه this time we continue weekly, لأنه every time we interrupt our weekly meetings, it's hard to come back. Okay, hopefully we are gonna run it weekly.
Excuse me, Dr. Hatim. I'm so sorry, but
أيوة.
I have
Sure.
question regarding phlegmon. When I found phlegmon, is that indicate this patient will develop or is already developing conduction defect, or this patient I will suspecting this patient can develop rupture?
Okay, good.
يعني what?
Okay, I get your point. So the phlegmon, يعني if you follow the abscess formation, root abscess formation, the first stage is thickening and induration in that area without the typical abscess formation. When we say abscess, means we have demonstrated cavitation. So that's a late stage. So we have the stage of phlegmon, then we have the stage of cavitation, then sometimes we have the stage of fistulation. Okay? But the phlegmon is just thickening. Once you see that thickening, especially if this one is associated with recent conduction problem, I think that's infective endocarditis till proven otherwise. طبعا usually the patient انت اصلا بتعمل له TEE بيكون في clinical suspicion of infective endocarditis. So if you have clinical suspicion of infective endocarditis and you see phlegmon, I think you have to deal with it as infective endocarditis. Okay? And if you are in doubt, لأنه you can be so doubtful, by the way, and I told you about the case and the disagreement among us as echocardiologists about whether this is phlegmon or just thickening and unspecific thickening. keep an eye on this patient by daily ECG and repeat echo as soon, like 3 days, 4, 5 days. Do echo again, and you might see things are evolving dramatically. And if you spot out any change in the rhythm, in conduction defects or stuff like that in the ECG is hypersensitive to any compressive effect on that area. So sometimes we see ECG changes before the full-blown abscess formation. So keep an eye on this patient by doing regular ECG and repeating TEE as soon as possible. But if a patient is based on strong clinical grounds as infective endocarditis and you see phlegmon, I think that's enough. You can treat as infective endocarditis. Okay?
Okay.
Yes.
Okay, thank you. Really, we can't thank you enough, Dr. Hatim.
You are most welcome, Dr.
جزاك الله خير
Thank you,
يا رب.
all of you.
شكرا لك كثير.
Thank you so much. يلا, see
شكرا
you
جزيلا.
next week, inshallah. Bye bye.
إن شاء الله.
Inshallah.